Hello, everyone. Welcome to NDARC's weekly webinar series. I'm Alice Havard, a researcher at NDARC, and it's my real pleasure to be hosting today's webinar. I would like to begin by acknowledging the Bidjigal people as the traditional custodians of the land from which I'm joining this meeting today. I would also like to acknowledge the traditional owners of country throughout Australia, noting that our audience are joining from many different locations across this vast country. We pay our respects to the elders past and present and extend that respect to any First Nations people joining the webinar today. Now, it is an absolute pleasure to introduce today's speaker, Professor Keith Humphreys. Keith holds the position of Esther Ting Memorial Professor of Psychiatry at Stanford University. He is world renowned for his research on addictive disorders and the translation of evidence into public policy. Indeed, he served as senior drug policy advisor in the White House during President Barack Obama's administration and has testified in legislatures in the U.S., Canada, and the U.K. In today's webinar, Keith will be talking about his experiences with translating science into more effective addiction-related policy. He will use a mixture of political science frameworks and experiential reporting to describe how policies around addiction are made and how they change and what role science plays in the process. We're also really lucky to have two local experts on this topic joining us for the discussion following Keith's presentation. This includes Wayne Hall, Emeritus Professor from the University of Queensland's National Centre for Youth Substance Use Research. Wayne has many years of experience with influencing alcohol and other drug policy in Australia and beyond. We're also fortunate to have Professor Alison Ritter from UNSW's Social Policy Research Centre join us. Alison is internationally recognised as a leading drug policy researcher. She is Director of the Drug Policy Modelling Program and Editor-in-Chief of the International Journal of Drug Policy. Keith and our two discussants will take questions from the audience after the presentation as usual, and you can log questions for them in the Q&A function at the bottom of your Zoom screen. Keith, I'm going to hand over to you now.
Thank you very much, and thank you everybody for attending this webinar. I am going to speak, I'm setting my clock to speak 35 minutes only because, as you just heard, you have two international leaders to add their own comments, and I'm sure you'll be very interested in them, as I will be. Let's start with a story. This is me underneath the White House going bowling. I think I look fantastic in this picture. I want to make that clear, even though I can't bowl at all. It's completely fake, but a lot of policy work sometimes feels to me like looking like you know what you're doing when you really don't. But the context of this picture is it's the night the Affordable Care Act, which I'll describe a little bit more as we get in, passed. And that was the big achievement we were all looking for in the Obama administration. And underneath the White House, there's a bowling alley that Harry Truman had built because he liked to bowl, and every president since has gone bowling at least once, if only for a photo op. And I was talking to Tom McClellan, who was my boss, an addiction researcher many of you will know, about the Affordable Care Act, and saying, that the two of us had advocated, along with our White House colleagues, to include substance use disorder full coverage in the Affordable Care Act. And that, in fact, had happened, and we were really glad. But that, we don't know if we were essential. There were other people who advocated for it. Maybe it would have happened anyway. Maybe someone had a better proposal, and our proposal knocked it out. And that's one of just the realities of policy. And I bring that up so that you realize when you work in policy, it's a lot. Working with a patient, you can often feel one-to-one. You can be fairly sure whether or not you've had an impact. Often in policy, you can't fully tell because there's so many players involved. And the second thing is that everybody only has partial information about what happens in policy. So you should keep that in mind as I tell you my stories. I can't be in every room and every discussion. No one can. Even the prime minister or the president can never fully explain why policy happens. So you just have to accept the limitations of all narrators, and that certainly includes me. Just before we leave the White House, I would like to point out there's a photo of Richard Nixon bowling. That's a foot fault. That guy cheated at everything. Okay, so evidence in policy. So first going to say, what is evidence anyway? Well, presumably evidence is something better than just pontifications of somebody who doesn't know anything about a topic, who hasn't spent time systematically thinking about and understanding. And that can be in very different ways. You can have the evidence of your experience, That could be your experience as a person, for example, who uses drugs or has been addicted or loves someone in that situation. There's clinical experience. I know many of you treat patients, so you will learn a lot about the experience of addiction and also even more so the experience of treatment from that. And then there's science, which could be epidemiological or molecular or neuroscience or clinical research or what have you. And the case I would make is that evidence should have a special role in policy and not be dispositive, but at least it is better than just doing things off the top of one's head or shooting from the hip or any of those other metaphors that policymakers love to use. Now, none of that is to deny that there's a lot of planted evidence, twisted evidence, misleading evidence. For example, look at this shocking increase in misleading charts. Really worried about that. The fact that that happens, and it's often enough to make you cynical, doesn't undermine the reality that evidence is valuable. It means we have to do a better job policing bad evidence, but it's not a case against the role of evidence in general. So I think this is just a not too lofty, but an important existential question for you if you're interested in this topic, which is why on earth would you want to, as a scientist or a clinician or anyone else, want to engage the public policy process? And the reason I ask that you think about that, if you want to do it, is that it's not extremely well incentivized. So if you're a professor, you're probably going to be rewarded more for your teaching, your research, your grants, your articles. If you're a clinician, you're going to be taking care of people. If you're an administrator, you'll be running the program you administrate. Why would you want to do this? There's not a correct answer to that question, but I always suggest to people that they reflect on it, because it may be this is kind of work that may come out of your hide, meaning like, you do it after you're done being paid, or you do it on a weekend when you'd rather be, relaxing or, having fun with your family or something like that. What is it that makes it sensible to you to spend at least some of your time trying to change policy? And here are some things I've observed, or what might be worth about common motivations for doing this. And I emphasize these are motivations, not types of people. You could have multiple motivations on this. For example, one is just intellectual fascination. There's a reason why we have a field called political science. It is very fascinating. How do laws come together? How do regulations actually work or fail to work? How do coalitions work? Why do people vote as they do? Those are really interesting questions. And if you're in the policy scrum, you can engage them, and that can be enriching for you, or maybe you want to write about it, or maybe it's just something you like to think about. For other people, it's a form of career advancement. That's probably more true if you're, for example, say in a think tank or some sort of policy-aligned organization where good policy research or policy dissemination may land you. Maybe someday you'll run for office, or you'll work for a powerful decision maker. Within academia, I wouldn't say it's a great tool for career advancement, but there are opportunities. If you become known as someone who's expert on policy matters in whatever substantive field that interests you, you may get to, be on extra panels at conferences because they think, oh, we should have a policy person. Or maybe if someone's editing a book, they think, oh, we should have a policy chapter. Let's ask so-and-so. They know policy pretty well. So there's some, even though a lot of the incentive structure doesn't work for academia, it can work for some. Third reason is self-expression. There's a literature in political science focused on why do people bother to vote? Now, of course, I know you have compulsory voting in Australia, but why do people bother to vote in places where it's not compulsory? Because the odds that, any one vote will shift an election are pretty much nil. So why do people do that? And at least one reason people do it is they just want to say, this is what I believe. I support these causes. It's important to me to express that. And in a free society, you have that right. A related motivation is badging. That's, I want to express this, but I also want people to know that I've expressed it. I want them to know what my values are. I want them to know who I'm expressing solidarity with. And there can be all kinds of reasons people do that. They want to express support for like-minded people. They want to put their reputation behind something. Also, sometimes people may want to badge themselves as having a particular policy viewpoint to avoid being misperceived as having a policy viewpoint that might be punished in whatever setting that they work. And then the last, not least motivation is actually changing public policy. People want to do it because they really believe that the law should be different or regulation should be different, and that is the ultimate motivation. Now, why do I mention all this? It's important just to know for oneself, there's not right and wrong motivations. These are all perfectly decent ones, but to recognize that there could be conflicts between them. And so you have to, if you're going to do this work, think about which do I care about the most. So let's say, for example, you think Mayor Smith is the dumbest person you've ever met. That's your genuine view. You would like to express that view. At the same time, you need to work with Mayor Smith to roll out her new homeless initiative. Well, if you give in to your need for self-expression by put on, Instagram or Twitter or whatever, Mayor Smith is the dumbest person I've ever met, you may not get that chance to then change the public policy. And situations like that will come up a lot, and you have to say, what is the most important thing that I care about? Again, no right answers, but just something to keep in your brain space as you go forward. If I want to tell you the thing that trips up the most people who try to put science into policy, it's the is-ought gap, which is an old concept in philosophy, I think from Hume, but don't quote me on that. And I'll just give this example. Here are three statements. Smoking cigarettes increases cancer risk. Taxing cigarettes reduces smoking. Government should raise taxes on cigarettes to reduce population cancer risk. Now, when I present this to public health professionals and academics, and I ask them vote by a show of hands, which of these are facts, all hands go up on all three. But all three are not facts. The first one is a fact. Second was a fact. You can demonstrate this scientifically. But the third one is an ought. It's something somebody should do. And why is that not a fact? Well, it's because someone could agree with those first two facts, but not agree with the third one. They could say, yes, I agree. Raising taxes does lower smoking and cancer risk. However, I think it's far more important to provide jobs on tobacco farms for my low-income constituents. That's not a disagreement where you can say, well, the science says you can't do that. That's not science anymore. It's a judgment. It's about politics. And that comes down to things like voting and democracy and the push and pull of our values and discussion, which is a good thing. We debate things, even though sometimes that means things will go differently than those of us in public health anyway would like to see them go. I wrote a paper about this with Peter Piot, which I think nobody read, but it was important to me to write anyway. I had just finished at the White House. Peter had just finished running UN AIDS. And we had both had the experience when we were in policy of scientists coming to us and saying, science says you have to do X, when X was not actually scientific. It was more, you have to embrace this policy or you have to spend budget this way, when those are really political choices. And so we wrote this paper, which is cited down there at the bottom, to try to articulate this, that scientific evidence is really important in public policy for all kinds of reasons, identifying problems, doing program evaluations, talking about the consequences of different policies. But just because you're a scientist doesn't mean you get to decide how other people live. And that's good. If you really thought the world was better if it was run by scientists, you really have to go to a faculty meeting and you would know that that's not true. We're not experts in governance. Nobody voted for us. We don't have a right to tell them how to live. We do have a right to tell them what the facts are and be listened to on those terms. And if you keep that in mind, you're more likely to be happy and effective than if you forget that there's a difference between facts and values. And so what that means is, even though people love to say evidence-based policy, there is no such thing as evidence-based policy. There's only evidence-informed policy. The basis is going to be in values and politics. Let's say you make it that far. This is a cartoon I like where a group of scientists sit around saying, Washington is looking to the scientific community for the answers. Gee, I've been waiting to say that my whole career. What's interesting is that sometimes when policymakers do say that, scientists sometimes freeze up and they don't exactly know what to say. And we suddenly realize things like, gee, our science isn't that good in this area, or it doesn't really address the question, or it can't be done on the time scale that the policy process needs. And again, this is not something to be right or wrong about, but just to caution you that the fact that science can contribute to policy doesn't mean that when we get those opportunities, we can always take advantage of them, because sometimes we're asked what the definite answer is, and we just don't know what it is. Okay, so what I'm going to do now in my remaining time is just, if I think I can get through all three of these, just give you three case studies of where evidence and policy in the field of addiction interacted. So the first one is an outsider example, meaning this was something I worked on when I was not in government. And for this to make sense to you, I have to explain two things. First, that the United States has the most complex and inefficient health insurance system in the developed world. We do not guarantee health insurance for everyone, unlike every other country. We have zillions of different complicated schemes to cover different patches of the population. It's a real mess, but it's ours. So we have to cope with it. The second thing is that prior to the passage of the legislation I'm going to talk about, insurers were under no obligation to cover mental health and substance use disorders at the level of everything else. By which I mean, like, it was perfectly legal to have a health plan that said, if you want to see a doctor about your bad back, there's a $5 copay per visit. But if you want to see a doctor about your depression or your alcohol use disorder, that's a $25 copay. And you could also have rules that said, you get, 50 visits a year for your bad back, but you only get 5 for your mental health or substance use disorder. Parity is the slang term in American politics for saying that shouldn't be that way. Actually, you should get the same benefits for both conditions. And that's what this is about. The real drivers of people, I think, for parity were people who were personally in recovery from addiction. This was an important meeting set up by Faces and Voices of Recovery, just for recovery. I was not there because I'm not myself in recovery, but there were lots of leading actors were there. That at the microphone is my friend, recently passed away, sadly, Congressman Jim Ramstad, who was a member of Alcoholics Anonymous. That's not giving away anything he hasn't said himself publicly. And then right next to him is his friend Paul Wellstone, who was in the U.S. Senate and came from a family with many mental health and addiction problems. Again, I'm not saying anything that he himself didn't talk about. But they had people like that, insiders, and they had lots of grassroots people. And this became their signature push. And it did get some traction in the American Congress. As it got down to being negotiated, there were a lot of technical questions. Some of them probably sincere, some of them probably cynically phrased about whether or not parity would actually work. And I was on a small team of scientists that worked through some of the Senate offices, being sort of a rapid response team for parity questions. And the most common one was, wouldn't this cost an awful lot of money? And fortunately, we were in a really good position to answer that question because federal employees, which is about 2 million in the United States, had parity in their health plans for a long time. So a very good team of researchers, Howard Goldman, Nate Azrin, and Richard Frank, did a couple of studies of parity, which we, and Richard was on our team, sort of hitting these balls back. And what that showed was when that was given to employees, it didn't actually cost that much to the insurance program, probably because there's trade-offs when people use mental health and substance use disorder care, they use less of, say, emergency department care. But it did make care more accessible by lowering out-of-pocket costs. And that held for kids and that held for adults. And bringing that back as rapidly as we could whenever we got questions and related kinds of questions, how many providers are there? How, will my district benefit? All that kind of stuff. And we were just there, basically the science team was like playing tennis. A ball would come from one senator to another, that senator, we would have to hit it right back really rapid with a quick memo. Look, here's the evidence that this will work. And thankfully it passed. At the very end of the George W. Bush presidency, there's Jim again on the right. And then the Kennedy family has been the family has probably done more for mental health policy in the United States than any other, starting with President Kennedy. And then that's his brother, Ted, who's in the Senate, and Ted's son, Patrick, my friend Patrick, who's in the Congress, and Senator Domenici. So just lucky to know before he passed away. He had a daughter with schizophrenia. He was very interested in this issue. But anyway, that had quite an impact on access to care. It covered what are called large employer plans. So companies that had 50 more employees who are the biggest buyers of insurance in the United States. And so it gave over 100 million people in the United States mental health and substance use parity. And there's been expansions of it later, which I'll get into. The implementation is uneven, not least because insurers sometimes resisted following the new law. But the nice thing is that if you're in that situation where someone you love, maybe your child has their first psychotic break or starts to develop an addiction, and you look at your plan, at least the plan will be on your side, and it will say your family member is entitled to the same benefits for this condition as they would if they'd had a heart attack or cancer or anything else. And that gives you a basis to fight if you have an insurer that isn't following the law. So this was in 2008 and a pretty important policy. And the fight goes on. So this is me testifying in the U.S. Senate, I think about 6 weeks ago, in the Senate Special Committee on Aging, about our Medicare program, which covers people age 65 and over, about extending parity to Medicare, which was not originally covered. And I think we have a real shot at that this cycle. That'd just be another way to sort of build on that. And what I'm talking here is I talk about evidence. I talk, about the rise of particularly substance use disorders among older people in the United States, the 400% increase in overdose deaths among older Americans in this century, And that evidence is relevant to the question of should we provide parity for older people, rather than assuming, as people kind of do incorrectly, that substance use problems are all something that you see in working age and young people. People forget that a lot of older people have them too. Now, did science make parity happen? God, no, absolutely not. There were a huge amount of politics involved. For example, between the people who wanted mental health covered and addiction covered, some of the people who were in mental health said, look, if we have addiction's more stigmatized, that'll drag the whole thing down. And some of the addiction people, including me, said, well, if you're gonna throw us off the bus, then you don't really have the moral props to start claiming that we should take care of mental health because you're being stigmatizing yourselves. That was all sorted out, but that was all politics, nothing to do with science. And then also was an incredible advocacy, particularly by people in recovery and other advocates, professional organizations, too. There were so many, when the bill was about to get onto the floor, the main recovery organizations organized so many calls to the Congress that actually shut down the congressional phone switchboard. It couldn't handle all these calls. And that secured a promise from the Speaker of the House to schedule a vote. It's Nancy Pelosi, and she's a person of her word. And she did, and it passed at the very end of 2008. So science, part of the team for sure, but not dispositive, because politics always matter. Okay, so that's an example being outside of government and using science. Now let's go inside of government. When I worked for President Obama, which I took a year off to do from 2009 to 2000, and basically the first year of his administration. This is a happy day for me. That's my boss on your left, and then his boss, who I know you recognize his boss. My boss is named Gil Kurlikowski. He was the White House Drug Policy Director, sometimes called the Drug Czar. And in his lap there is the White House Drug Strategy, a lot of which I wrote, which he presents to the president that day. And one of the critical goals, really the critical goal, was we wanted to do a lot of things around substance use policy, but most of all, we wanted to be included in the Affordable Care Act. So we had to present evidence on whether that made sense and what the impact would be. And there was a lot of evidence available. We had evidence from the British National Health Service, as well as the American Veterans Service, that if you medicalized addiction and mental health treatment, meaning you built it into the structure of healthcare, it was less stigmatized, it was higher quality, and people were more comfortable accessing it. We had clinical trials showing that alcohol interventions could work outside of specialty settings. For example, screening, brief intervention for low-risk drinkers. People might not make criteria, but still were worthy of help. We had very strong epidemiological information on the uninsured. In other words, the people who would get insurance if we passed the Affordable Care Act, would show that they had very higher than normal rates of smoking, and of drug problems, not so much alcohol, but smoking and illicit drug problems. And so that if you're going to cover them, you kind of had to cover those conditions. There was a big cost offset literature that was extremely helpful, gathered in different states that had expanded coverage for substance use disorder and mental health. And we converted that to little 2-page, very easy to understand documents that we worked with the White House Budget Office and with Congress, showing that if you covered these conditions, you actually saved money, things like ERs and also in criminal justice costs. We had clinical experience with patients, and a lot of patients and families spoke out on the value of care directly to members of Congress and to people in the White House. And the personal experience of families is also very potent, saying, that how important it was to them if we were going to expand health insurance, that these conditions be covered. And the thing we could say with the database behind us was if we were expanded mental health and substance use disorder treatment, it would have a big public health impact, and the cost would not be that much. And also would give us a chance to bring these conditions more into the mainstream health care system, including into the primary care system. What happened? Well, we did a lot of converting very complicated journal articles into little slick 1- and 2-pagers with big graphs, with maybe seeming oversimplified titles like expanding coverage reduces cost, or covering substance use disorder will reduce so many deaths a year. But they were I think, pretty effective, and they went around both the White House and the Congress, both by ourselves, but also because advocates would pick them up and then share them, and they'd be shared in the media and so on. Advocates were doing a huge job on their own, at least quasi-independently, trooping up to our legislative branch. and making the case with their members and people representing in Congress of the value of this. It helped a lot that parity had already passed. So a lot of members thought, well, I voted for this before and I'm still here, so I could probably vote for this too. Keep going. Anyway, it was passed. This hung right outside the Oval Office, the president's office. This is his signature on the bill on the Affordable Care Act. What did it do? Well, it expanded Medicaid, which is our low-income insurance program, as well as health exchanges, which are marketplaces where you can buy as an individual a health care plan at a reasonable price, and they're covered with Parity Plus, meaning not only did the benefits have to be comparable, but they had to be present, which was not always the case under the old parity law. I'm going to skip some of these other points because I want to make sure to get to everything, but just say that, if you look at independent analysis, but like Buck has a paper on Jeff Buck in Health Affairs, this is probably the most transformative thing that happened in substance use care in the United States in the 40 years since Medicaid and Medicare was passed. And it was also extremely important for mental health care, even though, mind you, this was not packaged as, or it really wasn't just a substance use care bill or a mental health care bill, it was a health care bill. But if you think that substance use and mental health are a core part of healthcare, it makes perfect sense that these were all wrapped together. This is an assessment of the impact. And, again, for time's sake, I will just direct your attention to the lower right-hand corner. This is the official estimate of how many lives were affected by this legislation. And it's over 60 million people. And it's a mix of people. It's people who had no insurance at all and then got health insurance from the ACA. And then there was another very large group who had insurance, but with kind of crummy benefits for substance use and mental health. And under the parity rules that we expanded in the ACA, their plan stayed the same, but their benefits got a lot better. So this pretty big expansion in access to care. The evidence matter? Well, the most important thing that happened was that President Obama, when he was a candidate, ran on doing this, and 60 million Americans voted for him. That's a hugely important thing, more important than all the journal articles ever published. I mean, without that, it wouldn't have mattered. And that many allies in Congress were elected too. But once that had happened, and the public had said, we want this, then evidence was absolutely critical to say, well, what should be in it? And what should be the benefits? And there are empirical answers to that question. It could have all been messed up. If we hadn't had data, we could have covered the wrong things or not covered addiction at all, or not covered mental health properly. So when the train was going, evidence was how we got on it and made the best use of that opportunity. Okay, the third example I'm going to give is an outsider example and a bit different, and something that happened in a different country, the UK, place where I've done a lot of work, a really different problem, much more a criminal justice problem than a strict healthcare problem. And that is, what do you do with people who have drink problems and get arrested over and over again for violating public safety, like drink driving or assault or smashing up shops in the street and that kind of things? This happens a lot in the UK. Hundreds of thousands of people a year are arrested for alcohol-related assault. There's plenty of alcohol-related problems. The plurality of people under criminal justice supervision have alcohol problems, and the system doesn't do a very good job dealing with them. What could you do? And for this, there is a evidence, well-studied solution, which is basically taking contingency management techniques and applying them in a criminal justice context. This was originally done in South Dakota, a state in the upper Midwest United States. And what they did with people after lots of things failing was they went to a model where they did not put people in jail, but they did forbid them from drinking. And you think, and by that I don't mean the judge threatened them, if I catch you drinking, there'll be trouble. Instead, they said, we're going to test you every single day to see whether or not you're drinking for the next 5 months. You can stay at home, you can keep your job, you don't have to go to jail, but every morning and every night, you have to come in and blow a breathalyzer. If the breathalyzer is negative, you get immediate reward, you continued freedom. If it's positive, you get an immediate consequence, which is you'll be arrested on the spot and held in a cell overnight for 1 night. Now, 1 night is not much of a penalty relative to for people like this. These are people who have been arrested, say, for their 3rd or 4th or 5th drink driving offense. A lot of them have been in prison. But it was a swift and certain penalty. And everything from behavioral psychology, neuroscience on down would tell you swift and certain consequences affect human behavior more than distant probabilistic consequences. In other words, it's much better to say, if you do this, it's very sure there'll be a small penalty, versus if you do this a lot, maybe someday we'll catch you and give you a very large penalty. Now, I wasn't, and by the way, also treatment is not required in this program. It is offered, but the incentives are tied around change in drinking behavior, not around seeking care per se. That's something you can do. It's not something you have to do. This has been studied extensively by the RAND Corporation. And if you just Google 24/7 sobriety RAND, you can see a large range of studies they've done. But this is roughly what happens to people monitored by this program. Maybe 60-65% go through 5 months without a single drink, which is pretty remarkable. And by the way, that's of course biologically verified, not a single drink. Then the later third breaks into two groups. There's about half of them are people who breach once. They're sort of testing, were you really serious about that? And then they find out, yes, we're really serious about that. And then they don't drink for the rest of the time. And then there's a group, about a sixth of all people, candidly, it doesn't work for. They have multiple drinking episodes. It doesn't seem to help. So it doesn't work for everybody. But if you succeed at this rate in criminal justice with people with substance problems, you are beating the curve by a very long way. So I'm not deterred by that in terms of the value of this. This is one of the many nice studies. I think this was first started by Nancy Nicosia about drunk driving, alcohol-related fatalities in South Dakota. And because I'm running close to the end of time, I'll just say there's been a dramatic decline. It used to be one of the most dangerous states in the union to drive. But as this rolled out across the whole state, it became one of the safest places in the country. The effects of this are very large. They even show up at the county level, such that when this was implemented county by county all across the state, drink driving arrests dropped by about 12%. Very importantly, domestic violence arrests dropped by 9%, even though none of the original cohort was sentenced for domestic violence. And there's a very important thing to understand about alcohol and crime, which is the vector is not the car, it's the drinking. So if you put an interlock on the car, the person can't drink and drive, but people who drink and drive a lot also drink and do other things, like they're often violent, including with their families. Take the alcohol out of their life, you get that spillover benefit. Also showed that statewide alcoholic mortality went down after the implementation of this program. Interestingly, the people on 24/7 are overwhelmingly male, but there were big mortality gains for women. When men drink a lot, they're often violent towards women or do other risky behaviors involving women. So women benefited dramatically from this program, even though most people on it were male. So how do we spread this to the UK? So there's a wonderful concept called the circuitry of enlightenment. It says around every problem, there's a group of people who are just interested in it. They may be in think tanks, they may be in hospitals, they may be in universities, they may be in politics. And they talk to each other. And an idea can get on the circuit, and even people who don't know each other can learn from each other. And that's what happened here. There are two friends of mine. Jonathan Calkins is a professor at Carnegie Mellon University. He gave a talk at the Oxford Policing Forum in Britain, and he mentioned 24/7 sobriety for about 3 minutes. That's it, out of a whole talk. Another friend of mine, Kit Malthouse, at that point was the deputy mayor of policing for London, and he was in the audience. And he thought, well, that's really interesting. I wonder if we could try that in London, where we have all this alcohol involved crime. And they've never met, they've never spoken to each other, and yet they were both on the same circuit, and there was this influence. Now, fortunately, I'm also on the circuit. I happened to be in London just very coincidentally when I was working for the president, and I read a quote by Kit in the newspaper saying, I want to try the South Dakota Sobriety Initiative. Now, at that point, I knew what it was. I'd been to South Dakota, looked at it. We'd endorsed it in the Obama administration and helped it spread to other states. So I wrote him a note and I said, if you want to try this in the UK, I'm happy to come over and help you do it. And he said, all right, come on over. So that's when the two of us started to work together. And we had a double act, him talking more about the policing part and also the reduction of violence against women, which is something he's very passionate about, as am I. And I talked more science and he talked more policy, but that made sense. He's a politician and a scientist. Over time, we accrued some other allies, a lot of excellent people. Probably one most important was Elora Finlay, who was subsequently the head of the British Medical Association. She's a physician, was also in the House of Lords and actually laid the amendments that got us to be able to pilot this in the UK. And we piloted it in South London. And because I'm short on time, I'll just say it worked really well. There's nothing really about basic behavioral psychology, behavioral economics that is particularly American. These are universal human principles. When people get prompt consequences, positive or negative behavior, that affects their behavior. And it worked pretty well there. That then led it to be rolled out across all London boroughs. And then we got the other factor that often matters in policy, which is luck. The mayor of London, when we did this, was Boris Johnson. Boris Johnson became the Prime Minister of England, and he made Kit the head of all policing for the whole country. And that gave Kit the position to expand 24/7 across all of England and Wales. And that's now the policy today. Get reports every month of hundreds of people all over are on this, and the effectiveness is still running about 91 to 94% of people completing their entire sentence without a single break. And there's interest now in other countries, including I just had a person reach out from the Parliament of Victoria, who was very interested in this. And I did some briefings for him, in Canada as well. So did evidence matter? Yeah, it did, because we had really strong evidence, all these nice RAND studies, as well as a lot of other studies of contingency management, but also took a lot of years of advocacy, and then the very good luck, which always matters, that a key policymaker found this interesting, moved from a position at a local level to a national level. He had the power to do an at-scale implementation. Never could have arranged that. 900 million papers would never have arranged it. That was the power of good fortune, and also his skill as a politician, of course. So what's common across these experiences? First off, evidence cannot and should not replace values overtly or covertly. Voting matters, democracy matters. We're not there to order other people about. The reason people listen to us is that we're good at assembling evidence, gathering evidence, thinking things through. But in the end, voters get to decide how they'd like. Evidence alone never carries the day, and shouldn't be expected to. And it's strange to me when people get cynical about it not carrying the day. Evidence is never the only consideration. Values matter. They should matter. Politics matters in a democratic society. But when the values in politics are there and create opportunities, when someone is elected and they say, I really want to expand healthcare, or I really want to reduce violence against women, or I really want to make our roads safer, evidence is invaluable, because you can have all that goodwill and all that political backing and do the wrong thing, or something that makes things even worse, or do something ineffective that sounds great. And this happens all the time. And the way we tell those things apart is by very good evidence. So we can say, look, don't press that button or turn that dial, pull this switch instead, and then you'll get the outcome that you want. Science is really good at that, and that's where you can have a huge impact as a scientist in the public policy process. I'm going to stop there right on time. Thank you.
Thank you, Keith. That was just fascinating. Okay, we're going to now welcome Alison and Wayne. Please turn on your cameras and mics. Excellent. There you are, Wayne.
Too fast with the clicking. Go on.
Yeah, too fast. Keith, we'll keep you on camera too, if you don't mind. And we're going to go to the Q&A, but first of all, I just wanted to ask Wayne and Alison if they would like to offer a few reflections on the work that you've just presented, and we might just start with you, Alison, if that's okay.
Sure. Thank you very much. I'm coming from unceded and stolen Vegetable land. Thanks so much, Keith. I mean, it's fantastic to hear from someone who's actually been in the trenches and really knows this stuff. So really appreciate your insights. A few things that struck me when you started with this idea of what is evidence. We use the word knowledge because we think that expands it out a bit, and the different types of knowledge. And I can commend a paper led by Michaela Kowalski here at DPNP. She classified evidence in relation to alcohol policy making and found 31 different types of evidence in the alcohol policy making process. It's published in Drug and Alcohol Review last year. And I think thinking with a broad suite of evidence is useful. I love the stuff about values. It's a core research activity here at DPNP to study the role of values. As researchers, we misunderstand the role of science and don't appreciate the role of values and the importance of the fact-value distinction, as you say. I think we also, as researchers, misunderstand the role of policy and how policy actually gets made. And there's some really good political science theories, the advocacy coalition framework or the multiple streams for people who are interested, email me. We've got papers using those particular frameworks to understand how decisions get made. And as Keith has said, it's a real reminder that research evidence is but one input into the policy process. And the third kind of reflection I had was this idea that it's, you know, we do the research and then it's all about the politics. And somehow this politics, or it's political, becomes a kind of black box. And there's not much empathy amongst researchers for the complexity of being a politician, being elected by citizens. And I think we could do more work to try and understand politicians. And in fact, one of my colleagues, Paul Kaleta here at DPMP, and I are doing some work with retired politicians to try and better understand the constraints and possibilities that they have in relation to drug policy while they're in office, with the intention to enable researchers to have more, perhaps some more empathy, but certainly a greater knowledge and understanding about the particular role that politicians play. And my last comment, which is back to values again, is that we've talked about the role of values in policy making, and I think you've made that point really well, Keith. But what about our own values as researchers? And, you know, science is not value-free, just like policy making is not value-free. And we all carry our own values with us, but we rarely talk about that as researchers and as scientists. And with another colleague, Meg Greeley here at DPMP, we're about to start some research on researcher values and how that might intersect in the process of translating research into policy. So they're my quick reflections. Thank you.
Thank you. Did you want a response from me, Alice, or do you want to do at the end? What would you prefer?
Well, if you have a brief response, that would be great.
Okay, I thought that was great.
Yeah.
That's my brief response. I like this stuff about knowledge. In fact, the circuitry of enlightenment was coined by Carol Weiss. She often more talked about knowledge than evidence.
Yeah.
And someone who had a real impact on me, and someone I got to work with, a sociologist, Thomasina Borkman, wrote about types of knowledge and about there's professional knowledge and then there's experiential knowledge and sort of what they were. And this is the last thing I just want to underscore. Researchers have values, and everyone knows that. So it's really better to say it than pretend otherwise. You know, sometimes here we're going to replace values and morals with science. No, that's not possible. There's no, and no one's believing it anyway. If you walk in and say, I have no values, I just think you should do this. So we're actually better off by saying, yeah, I'm doing this because, I'm a feminist. Violence against women appalls me. That's why I'm interested in this problem. I have that bias, and just say it. And actually people trust you more than if you say, no, I have no real opinion. I do whatever, that kind of thing. So we could do a better, I think I really appreciate what you're saying. We need to do a better job with our students and all that too, of saying it's okay to have values. You just sound silly if you accuse other people of having values and say you don't.
Yeah.
And also, would you really want to work with someone who had no values at all? Yeah. That's right. But thank you very much, Alice.
Thanks, Keith.
Yeah, thanks, Keith, and thanks, Alice, for those interesting points. It'll be we'd love to have you back actually when you've got some findings from that values work and the interviews from retired politicians. Wayne, would you like to add some points?
Yeah, just a few, and partly to one of Alison's points about being more sympathetic to the predicament of politicians, having been involved in policy process. A lot of policy is of the sort that I think Keith described in the early examples of what Max Faber described as the slow boring of hard wood, that there's not a lot of progress that's made, people working, and often then opportunities arise, often as a result of perceived public crises around certain forms of drug use, as in Australia in the mid-80s around heroin use, and as now around adolescent nicotine vaping in Australia. And there seems to be a perceived necessity. We've got to do something quickly, and it's got to be seen to be authoritative. Governments need to be doing something, spending money, and often you have certain charismatic people with personal credibility, often good media connections, who are out there advancing particular solutions. And we've seen that in Australia with the mothers of children with cancers and intractable epilepsy, basically helping to engineer the passage of legalisation of medical cannabis use. And we're seeing it, I think, now with around vaping, that mothers of adolescent children who are journalists are out there really ramping this issue up. And often what you end up with is a polarization around policy responses that make sensible policy difficult. And politicians then often don't know how to respond when you've got two competing sort of narratives out there from articulate and credible people advocating for very different things. As in the mid-80s, well, really the early 90s, a war on heroin or a heroin trial. They were the policy options that were up for debate at the time. I mean, I think Bob Carter, his credit, helped to get around that by organising a drug summit and forcing people to present to one another and sit around in groups and deliberate. And that took a lot of the heat out of the issue and I think led to more sensible policies. So I agree with Keith that a lot of these opportunities arise, and the real role of researchers is really to be ready with helpful advice. A colleague of both Keith and mine, Griffith Edwards, famously said that data left to its own devices mumbles in low tones. That what you need is sort of authoritative, integrative, and accessible ways of presenting evidence that politicians can see the relevance of to the policy issue that's in front of them. And I agree with Keith that you need to be realistic about what's possible in a liberal democracy and what sort of contribution one can make to research in the long run. So I'll leave it there. So there's a bit of time left for questions from the audience and more discussion.
Yeah, great. Thanks, Walt. Wayne, sorry.
I'll just respond very briefly. I'll again say great. Absolutely agree. And just to highlight the 2 points, the limited power of policymakers. Like right now in the United States, we have this terrible opioid addiction and overdose crisis. We're trying to expand access to things like methadone. Our methadone, if methadone were invented today, it would absolutely not be what it is. But over 60 years, there's an entire clinic system and regulations and stakeholders who like it that way. So people, policymakers would love to start over, but they can't because there's 60 years of history and tradition and rules. And so they end up fiddling at a low level and people get mad at them. But in fact, the people they should get mad at are actually dead. The people who made decisions 20 or 30 years ago, and they're left with this decision accretion. And also in the polarization point, I think that's one place where evidence can be really helpful. Like now I've been working with the state of Oregon, which is kind of going through a polarized debate where some people are saying the only two drug policies are either a racialized, incarceration-focused war on all drugs or no controls on anything. And evidence can be really powerful to say, actually, there's lots of examples around the world between those two things. It's not really a switch, it's a dial, and you could turn it here and you could turn it there. You have more options than you think you do. And we've got evidence showing what those different options might be. So I just want to add to that. Thank you, Wayne.
Thanks, Keith. All right, we might jump to the Q&A first, and I am going to ask the first question if that's all right. And that's around, what advice would each of you give to early career researchers that are interested in getting their research in a position that it is considered in informing policy? So Wayne touched on making evidence, accessible. Keith, you talked a lot about relationships. So I wonder if there's one key thing that each of you would nominate as something that early career researchers might think about if they really wanted to have a role in trying to inform policy.
So I'll go first. So students come to me all the time and say, I want to make policy. What do I do? And that's a bit like saying, I want to be famous and rich, or I would like political power. How do I do it? And so I'd say is think about the other side. Why would anyone give you any power or influence? It's because they think you know something. So the most important thing actually when you're early in your career is not to go hanging around the Congress or whatever. It's to become really good at some area as a scientist. So that you can instead go into I'm just generically into policy. Instead, you could say, I did the most important study of the effect of maternal substance use on birth outcomes. And I know a lot about it, and I know you're writing a bill about it, and I can help you. You make yourself valuable. So be patient, Do that first so you can bring something to the table, and then people will want to have you involved because you'll know something.
If I can springboard off that, because there's a whole bunch of dissemination strategies, you know, academics publish behind paywalls, you've got to disseminate. But actually, I agree with Keith. The most important thing is to do high quality research, actually. And the South Dakota 24/7 sobriety, what's extraordinary about that is the quality of that piece of work, that, you know, time series analysis that they did. That was really high quality research. And if you're not doing high quality research, there's no point trying to translate it.
Mhm. Yeah, great. Wayne, what would you like to add?
I'd agree. I mean, you've got to have some goods to offer to influence policy. But I mean, once you do that, if you're wanting to get into it, I think spending time making submissions to parliamentary inquiries is a good way of sort of acquiring the skills. Probably worth thinking about spending some time with policymakers in particular fields. I mean, it's not easy to organise, but I certainly did quite a bit as an advisor to various parliamentary committees, more by accident than design, back in the 1980s. And that gave me a real insight into the sorts of challenges that politicians face, the competition for their attention from myriad issues, and, you know, where a particular issue might fit, and that they really only start to pay attention when they're forced to, largely because it generates complaints from constituents and media stories and so on. So I think I'd agree with the importance of having something to offer. Having some expertise to offer is the first thing.
Yeah, great. Okay. All right. I'll just remind the audience that you can pop some questions in the Q&A if there are any for our panelists. We have one here from Professor Don Weatherburn from NDARC. Going back to your point, Keith, around the evidence and the award. So he's commented that academics sometimes seem to think that having expertise in a certain area guarantees expertise in what governments ought to do with that in response. And he's assuming that you don't agree with that.
I agree with Don Weatherburn as a matter of policy. And I agree with him here. And something Peter and I wrote about in our piece is that it is undemocratic, actually, if it's you know, to start saying, because I'm a scientist, you have to listen to me. And I'll give you an example of that. You know, William Shockley won a Nobel Prize for his work on electrical engineering, and then he spent the rest of his life saying that blacks were inferior, and you had to believe him because he was a Nobel laureate. I mean, what a load of crap. And that was a misuse, an abuse of science, and abuse of democracy. So you don't want to yield to that temptation to try to use your authority.
Yeah.
I've just got a slide up, which is where Australian policymakers go for evidence. It's a little bit old, but I think people might be interested to see this in terms of the advice. I'm assuming you can see this.
Yes, we can.
So we asked policymakers, think about the last time you made a drug or alcohol related policy decision. Where did you access research? 100% of them phoned someone. So if you're not on speed dial, 100% of them consulted a technical report or bulletin. Half of them used the internet. That's not Medline, that's not Google Scholar, that's Google. Half of them used National Drug Strategy household survey data. Half of them rang another jurisdiction to find out, and only 35% of them used academic literature. So if you're relying on academic literature as your way to influence policy, you're really missing out. And publishing in the grey literature, getting your material up on the web through bulletins and so on is really the way to go.
Yeah, just one other thing. Carol Weiss studied in the U.S. Congress how much discretionary reading time you have a day, and the average is about 15 minutes.
Yeah.
So think about, if that's your audience, shorter is better.
Yeah. Yeah.
Right. And another question here about if you have any suggestions on how to reduce misinformation, which may have the opportunity to influence policy. Tricky one. Keith, do you have any thoughts on that? Oh, you're on mute at the moment.
being muted is appropriate because
Yeah.
lots smarter people than me are trying to work on that problem, and it's a massive, massive, massive problem. It goes way beyond what we're talking about now in the age of the internet. So no, I wish I did, but I don't. All I can say though that relationships matter a lot. So, you know, if you like if you were going to decide you wanted to lose 5 pounds and you Googled, you know, you'd get 80 million diets and you wouldn't be able to tell which one. But maybe you know someone, you have a friend who lost 5 pounds, says, you know, I did a little exercise, did this and that, and then that is useful to you as a quality indicator. Somebody you trust gave you good info. So at least the fact that enough at this point, a lot of policymakers know me personally, worked together for a long time, is probably the best defense I can offer against misinformation, which, you know, spreads like wildfire on the internet, as we know.
Yeah. And there are services like the AID Media Watch, which, you know, critique, sort of fact check Australian media around alcohol and drugs. There are movements like the Public Understanding of Science, which is all about trying to increase the kind of scientific literacy of the general population. But I mean, this is a problem, as Keith says, much, much bigger than alcohol and other drugs.
Now, we've got a couple more questions, but I'm not sure we're going to be able to cover them. So we might pass them on to you afterwards, Keith, because I'm just looking at the times. I think we might need to wrap up, but I would like to say a massive thank you. It's been such a riveting conversation, really informative. And yeah, to thank you, Keith, and Wayne and Alison all for joining. And thanks to the audience as well for engaging in the discussion.
Thank you.
Thank you very much.
Okay. Bye.
Bye-bye.
All right, we are